Hello and welcome to another intensive care at home and intensivecarehotline.com live stream. Welcome to the live stream, and I also want to welcome our viewers on replay. Today's topic is MND, motor neuron disease in ICU, BIPAP, tracheostomy and discharge home with 24/7 intensive care nurses. It's Patrick Hutzel here from intensivecarehotline.com and intensivecareathome.com, where we help families of critically ill patients in intensive care make informed decisions, have peace of mind, control, power and influence, making sure your loved ones always get best care and treatment so that you can make the best decisions in the best interest for you and your family and for your loved ones. And if you're new to this channel, make sure you subscribe, click the like button, hit the notification bell, so you'll get notified when I go live every week, and so you get all the updates that I publish here during the week as well. Today's topic is one that affects thousands of families worldwide. MND, motor neuron disease in ICU, BIPAP, tracheostomy and discharge home with 24/7 intensive care nursing. And I can speak from, decades of experience. I've worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. I've been consulting and advocating for families in intensive care at intensivecarehotline.com since 2013. I have been successfully running intensive care at home since 2012 here in Australia. I've been involved with intensive care at home also 25 years ago in Germany, where we were pioneering the model there. So I speak from decades worth of experience in intensive care as well as with intensive care at home, and you'll get a real expert video to do expert insights about not only the intensive care space but also about the intensive care at home space and how it relates to MND or motor neuron disease. We were looking after ventilated patients with tracheostomies with MND in Germany 25 years ago, and we're now doing the same here in Australia, right? And I will talk more about some case studies as we go along. Now, we usually go for about an hour, in these live streams, and I've given a little bit of a bio about myself, why I do these live streams, what's my background, and I've been having this YouTube channel now since 2012 or 2013, and we've helped thousands of families here of critically ill patients in intensive care, and that's just the reality. That's just the reality, and we can help you as well. So let's start. So quick overview for today's topic. We start talking about, MND in hospitals, first of all, and then what can hospitals do to prepare your loved one for not only evidence and best care and treatment, and then for home care, maximizing quality of life at home. How can hospitals prepare you and treat you? And then we'll talk about what that looks like once your family member is at home, either on BiPAP, CPAP, cholecystectomy or then with a tracheostomy, if that's what you and your family choose to have. It's all about choice and control here. We're not trying to talk you into anything here, but it is important that you and your family have choice and control. So motor neuron disease, or MND, also known as ALS in many parts in the US, affects the brain and spinal cord, leading to muscle weakness and eventually respiratory failure. Many patients are admitted to ICU because they can't breathe on their own and need BiPAP or invasive mechanical ventilation. When that happens, families are often pressured by ICU team to make end-of-life decisions quickly without being given all the facts or options. That's where we come in at intensivecarehotline.com to educate, advocate, and negotiate your options on your behalf, also knowing what we can provide for you in the community. Most hospitals don't even know what the options are in the community, for example, with intensive care at home, whether that's on BiPAP ventilation, CPAP ventilation, or whether it's on ventilation with tracheostomy. So many patients initially start out on BiPAP ventilation in ICU, right? That's often what gets them into ICU. And I can give you a real world example here. Recently, we took a young MND client home who was in ICU for 4 months on BiPAP. Initially they weren't on BiPAP, but they ended up going into ICU with a chest infection with an aspiration pneumonia. They then ended up on BiPAP and obviously could only leave ICU safely with intensive care at home, 24-hour intensive care nursing at home, which is what we're doing for this particular patient here. So I know exactly the interface between ICU and home care because I've seen it many times. So BiPAP, or bi-level positive airway pressure, is often the first line of respiratory support in MND. It's a non-invasive ventilator that helps patients breathe without the need for intubation or tracheostomy. However, here's the key. BiPAP ventilation for MND patients must be closely monitored 24/7 by CCRNs or critical care registered nurses. Regular nurses, let alone disability carers, are not trained to handle ventilation alarms, mask leaks, CO2 retention, or oxygen adjustments. Families are often told that BiPAP can be managed safely at home with the right 24/7 clinical support, not just in ICU. Families aren't told that BiPAP can be managed safely at home with the right 24/7 clinical support, not just in ICU. But in hospitals, MND patients are often stuck because no one tells them that home care with ventilation is possible with intensive care at home, and it's actually evidence-based. And the reason it's evidence-based, we published the mechanical home ventilation guidelines that you can find on our website at intensivecareathome.com. The mechanical home ventilation guidelines are evidence-based, and they clearly highlight that exclusively ICU nurses with a minimum of 2 years ICU nursing experience are safe to look after ventilation, whether it's invasive or non-invasive ventilation at home, with or without a tracheostomy, right? Anything less than that is clinically unsafe, and people have died with any other standards but the mechanical home ventilation guidelines, and I have evidence to prove everything that I'm saying here. So, as MND unfortunately progresses, some patients lose the ability to clear their airway or tolerate a BiPAP mask. They also often, when BiPAP is started, get commenced on a cough assist machine to clear the airway. So that's also something that often happens when it comes to MND. At that point, tracheostomy ventilation may be recommended, or for some patients who don't want a tracheostomy, they may choose the palliative care route. But what you need to know here is that you have a choice, and that a tracheostomy is definitely an option, irregardless of what some hospitals tell you, regardless of what some motor neuron disease associations might tell you. So at the point when tracheostomy ventilation may be recommended or is becoming an option, it's critical that you recognize that, or it's critical that you have someone on your team who can help you recognize when you need to start talking about it, you need to start thinking about it, and when you need to look at these options. In many ICUs, ICU teams will tell families there's no quality of life with a tracheostomy, or you can't take a lot from home with a tracheostomy, which is simply not true. Thousands of MND patients around the world are living at home on a ventilator with a tracheostomy with 24/7 intensive care nurses managing their airways, ventilator settings, suctioning, medications, nutrition with a PEG tube. And that's where intensive care at home comes in. And we'll talk more about that in the second half of this live show. Also, many of you watching this video would have heard of Stephen Hawking, a very famous scientist in the UK who passed away a few years ago. He had MND, and he was living on a ventilator with a tracheostomy with 24/7 critical care nurses for decades. And because he was a scientist and he could continue his work, he was a researcher and he was contributing to society by keeping him alive. So keep that in mind. Often long-term care is being perceived or labeled as, people are not contributing to society. It's not worth for people living and all that sort of nonsense, It's up to the individual, and we as a society have to take responsibility for enabling people to live if they want to. I do see that as our duty here at intensive care at home, but also with intensive care hotline. It's our mission, actually. We are on a mission here to prevent people from dying prematurely if they don't want to. So let's talk about the role of cough assist machines in MND. I briefly touched on that, but let's do a deeper dive here. MND patients often can't cough effectively due to muscle weakness. That's why a cough assist device is essential. The cough assist works by applying positive and negative pressure to simulate a natural cough, helping to clear secretions and prevent pneumonia. Used in combination with BIPAP or tracheostomy, it reduces the risk of ICU readmissions, it reduces the risk of pneumonia, it reduces the risk of atelectasis, and it improves comfort and safety. In hospitals, cough assist devices are often underused because staff don't have the training or the time, but in the home setting with the right critical care nurses and the right physiotherapist, it can be a life-saving tool. It's interesting, when I first started working in ICU over 25 years ago, the cough assist was being used, and then it sort of disappeared. And then I've always seen it in the community with intensive care patients. And it's a crucial device. It's a crucial tool in our toolbox to keep our clients at home predictably and permanently, right? So don't underestimate the use of a cough assist for MND. If your family member is in ICU right now, and if your family member is in ICU right now, and they're not using the cough assist with MND, you should question that, right? So, what are common ICU challenges for MND patients? Families in ICU tell us over and over again that ICUs often pressure them to withdraw life support prematurely and way too soon without having all options discussed transparently. They don't offer options for home ventilation, whether it's BiPAP home ventilation or whether it's home ventilation via tracheostomy. They try to create guilt around choosing tracheostomy or prolonged ventilations, citing that your loved one won't have any quality of life. Well, ask Stephen Hawking. Now you can't ask him any longer, but given that he wanted to live for decades on a ventilator, you cannot say that he didn't have any quality of life. He was a very intelligent guy. He could have said to his family that he no longer wants to live. He didn't do that. He cherished every moment. So don't let anybody guilt trip you around choosing tracheostomy, prolonged ventilation, and don't let anybody guilt trip you about your choice, because it's your choice and your choice only. ICUs also fail to provide consistent updates or clear communication, and this is where I always strongly recommend that you need to get access to the medical records from day one. And by the way, getting access to medical records is not a privilege, it's a right. Okay, many families in intensive care keep telling us that, oh, the ICU team says we can't get access to the medical records. That is a whole lot of nonsense. It doesn't matter where you are, in which country, it is a right, not a privilege. And I'll just leave it there. I need to say that if you can't get access to the medical records, it's your own fault. We never had a problem getting access to the medical records. You just need to know what questions to ask. You just need to know how to go about it. We never had a problem. It probably also comes down to having intensive care insider knowledge, of course, which is what we have here, but you have the right to access medical records, full stop. So with intensivecarehotline.com, of course, we help families to understand what's really happening in ICU. We ask the right questions. We advocate for time, options, informed decisions for access to medical records, and so forth. If you need one-on-one guidance for your MND loved one in ICU, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. So let's now look at transition to home options with intensive care at home. So what happens when ICU teams say we can't do any more? Your loved one can't go home on a ventilator. Well, that's complete and utter nonsense. Ignorance is not bliss. So if ICU teams tell you that, they're ignorant, and in this case, it's not bliss because it's life or death. And if the ICU team tells you we can't do no more, or your loved one can't go home on a ventilator, it's simply not true. And that's what we do now. That's what I want to talk about now. We will discuss how to safely discharge the MND patient at home with BIPAP or with a tracheostomy and 24/7 intensive care nurses, so that the intensive care can come to your home and you no longer have to stay in intensive care, and we optimize and maximize your quality of life at home. But before we do that, make sure you like the video, share it with anyone who has a loved one in ICU, and comment below where you're joining from. I love hearing your stories and your questions so that I can make my content around what you want. So, bring your MND patients home with BiPAP or tracheostomy with intensive care at home, and you can find more information at intensivecareathome.com. We specialize in taking long-term ventilated adults and children home from ICU safely, predictably, and permanently. We provide 24/7 intensive care trained nurses, CCRN trained, who manage BiPAP ventilation, tracheostomy ventilation, suctioning, secretion management, cough assist management, PEG feeding, nasogastric tube feeding, medication administration, full airway management, tracheostomy changes. All of that is associated with, intensive care nursing at home we do. This is hospital level care in your home. So what are the benefits of home care for MND patients on ventilation, whether it's BiPAP ventilation or tracheostomy ventilation? Well, the first one is the most important one. It improves your quality of life. You are in your familiar environment, your family is in your familiar environments, surrounded by loved ones. You can't beat home, full stop. You cannot beat a home care environment compared to a hospital ICU environments. Better sleep and comfort, no alarms, bright lights, or constant interruptions like in ICU, where the lights are on 24/7, people talk 24/7. It's just not an environment that's conducive to healing. Next, reduced infection risk, fewer hospital-acquired infections. As you all know, if you are in ICU, the spread of infections is real and it's very prominent. And the simple reason for that is that there are many sick and infectious patients in ICU, and no matter how good doctors and nurses do their hand hygiene, washing their hands, using hand sanitizers, wearing aprons, changing the aprons from patient to patient, there is still a very high infection risk that you get a transmission from another patient with an infection that could, quite frankly, be deadly. Next, Family involvement. Families can participate in care and decision-making daily. You are in charge. You can tell us what you want, how you would like your day to look like. And last but not least, it's cost effective in any case, really. It is much cheaper for the healthcare system than keeping someone in ICU long term. So what that looks like is an ICU bed costs $5,000 to $6,000 per bed day, depending a little bit on location. Intensive care at home costs half of that. So the health service funding bodies will have an interest in our model because they're saving money, right? So in essence, we have a proven model that works. And our clients are living proof that intensive care can be safely delivered at home. We have by now delivered millions of hours of intensive care at home nursing, right? We have proven this model beyond the shadow of a doubt. Next, we talked about cough assist use in ICU. I also want to talk about cough assist use in a home care setting. For MND patients at home, cough assist should be part of the daily care routine. For most patients, there's exceptions. Our nurses are trained to use the cough assist alongside BIPAP or tracheostomy ventilation to maintain airway clearance and prevent respiratory complications. So, we feel very confident and safe with this approach. So let's look at some case studies. We looked after an MND client in Sydney not too long ago. He has passed away now, but looked after him for a number of years. The hospital told his family initially he could never go home. We got involved. Initially, we got involved because the carer model was failing. He initially had a carer model with 24-hour support workers, but that was failing, of course, and he was at risk of dying. And that's how we got involved with 24-hour intensive care nursing instead. I mean, you can't have basically an ICU patient being looked after by disability support workers. You can't even have registered nurses without ICU experience be looked after by general registered nurses look after BiPAP ventilation or tracheostomy ventilation. It's not part of their skill set. And we were avoiding multiple readmissions for this client, multiple readmissions, right? That's what I'm saying, intensive care at home. We keep you at home safely, predictably, and permanently. I can give 3 other case studies for MND clients where we were involved in the discharge from ICU. We have another MND client who would be in his mid-40s now, and he first got admitted to ICU in 2019 with an aspiration pneumonia, ended up in ICU, ended up with a tracheostomy, and we took him home. And he's been at home since 2019 on a ventilator with a tracheostomy, and he's living with his family, with his wife, with his son, and that is what's possible. Another case study that we have is a lady in her early 60s, also got diagnosed with MND in 2022. She was on BiPAP initially, of course, ended up with a tracheostomy, and is now at home with 24-hour nursing care. For all of those clients, what needed to happen is, and she's also in Melbourne, what needed to happen with these clients, for all of these clients, yes, we needed to do the advocacy for NDIS funding for 24-hour critical care nursing, but we've done that successfully with all of these clients. And again, that's what needs to happen, because otherwise these clients would have passed away. And on that note, I also need to say that I know of cases of MND cases that were in hospital and where families approached us afterwards, where they said, oh, if we had known about intensive care at home, we would have contacted you earlier. And the reality is that families in ICU were told that there's no hope, there's no treatment, we should just move towards palliative care as soon as possible. And that's unfortunately what hospitals have done, because the families didn't know any better. And this is why I'm saying you need to do your own research. You need to start thinking for yourself. These are life or death situations. You can't just leave them up. You can't just leave them up to coincidence. You need to take charge, and you need to start thinking for yourself, which I know you're doing if you're watching this or if you're reading through the transcript, right? I know you are thinking for yourself, but you can't take whatever the hospitals say for gospel. You can't even take for what sometimes even MND associations are telling you. Sometimes even MND associations might tell you that there is no funding for critical care nurses, and nothing could be further from the truth, right? Nothing could be further from the truth, right? Another case study that I can give you is, I briefly touched on that earlier, but I do want to talk about it in more detail. So there's a lady that we took home from ICU probably about a month ago now, maybe 6 weeks ago. She was in ICU for 4 months. She was living at home initially, just, as she was going through the disease process. And she wasn't on BIPAP, she was wheelchair bound. She didn't have too many respiratory issues just as yet, but she then ended up with an aspiration pneumonia, which is often what triggers BIPAP ventilation. And then another aspiration pneumonia is also what often triggers tracheostomies, right? Unfortunately, that's the way things are going, or that's how the disease process unfortunately unfolds, right? And she then ended up in ICU with chest infection / pneumonia, ended up on BiPAP, became increasingly BiPAP and cough assist dependent, had a PEG tube, also had an IDC, a catheter, and she was in ICU for 4 months until the funding was organized, until, we set up a team. And here we are. A few months later, she's now back home with her family, with her young kids, with her husband. And, she doesn't want to go back to a hospital, of course. So how would you even get started with intensive care at home if you are in a situation like that? Well, the first thing is, if your loved one is in ICU with MND, whether it's on BiPAP, whether it's you're contemplating a tracheostomy, whether your loved one has a tracheostomy, and you are told there are no options, the first step is contact us at intensive care at home. That's the first step, right? We can assess your loved one's situation, liaise directly with the hospital, organize equipment and staff, help you with nursing assessments, with funding, help you with an NDIS specialist support coordinator, and help your loved one to go home safely, predictably, and permanently, right? So you must know that there are options out there that have longevity, that have merit, right? So it's all there. So I also forgot to welcome our viewers that watch this video on replay, because I know, for any of you that can't make it to the live show, a lot of viewers come and watch this on replay. So I also want to welcome you. But obviously your best option is always to connect with me live here, because that is your best option to ask your questions and talk to me directly. So when you are at the interface of, also, let's just say you are, you or your family member have MND and you're watching this, not only might the hospital be negative, we also know that sometimes NDIS support coordinators can be negative. And I want to give you an example here that I just had this week. We have an inquiry at the moment for a ventilated client that's being looked after by disability support workers. This is basically a quadriplegic client who's ventilated with a tracheostomy, and he's been looked after by support workers. Now the family is having second thoughts and they want to change to critical care nurses, realizing that disability support workers are simply dangerous to look after ventilated and tracheostomy clients. And now they finally found out about us, and they're asking us, what do we need to do to get 24 intensive care nurses? They also realized that there's multiple risks by being on the ventilator. There's multiple risks by support workers not being able to interpret ventilator settings, ventilator numbers. We just found out by visiting this client in their own environment that, is at high risk of sustaining barotrauma or pneumothorax, and nobody picked up on that. And how would you if you're not intensive care trained, right? So if you're watching this and you have disability support workers at home, whether you're on BIPAP, tracheostomy, with or without ventilation, you are at super high risk of either sustaining damaging medical emergencies, or even worse, you're at risk of dying. I can give you numerous examples where ventilated clients have died in the community under a support worker model. That's how dangerous this is. So here is, what happened this week when I spoke then to the NDS support coordinator about the client that wants now 24/7 critical care nurses. And this NDS support coordinator told me that, the NDS won't fund critical care nurses. That's not going to happen. I've never seen it. And I said, well, I respectfully disagree. They do fund 24-hour intensive care nurses with the right level of advocacy. Otherwise, intensive care at home would not exist, right? Intensive care at home would not exist otherwise, right? We wouldn't be hiring hundreds of critical care nurses in the community if there wasn't any funding, right? Very simple. So that's why, and in this situation, if this NDS support coordinator either doesn't want to learn or, is small-minded, you should come to us for your NDS support coordination needs. We have our own NDS support coordinators that know about the steps that need to be taken to get 24/7 intensive care nursing for disability-related funding, right? Especially when it comes to ventilation, tracheostomy, BiPAP ventilation, tracheostomy ventilation. Even for tracheostomy without ventilation, you need 24-hour nursing care. It's all evidence-based, right? So you really need to build the right team around you when you want to go home from ICU with intensive care at home, but even if you are at home already and you realize you have the wrong level of support, and that the wrong level of support is putting your or your loved one's life at risk, we can help you with all of that to turn things around, right? That also brings me to the evidence-based mechanical home ventilation guidelines. So when we provide services at home, it's evidence-based. So what does that mean? Evidence-based means we are sending critical care nurses 24 hours a day for BiPAP, CPAP ventilation, tracheostomy management at home, tracheostomy and ventilation, right? And that's evidence-based. So when you go to our website at intensivecareathome.com, there's a section, the mechanical home ventilation guidelines. On these mechanical home ventilation guidelines, you will see that exclusively critical care nurses with a minimum of 2 years critical care nursing experience can safely manage ventilation and tracheostomy at home, whether it's invasive or non-invasive ventilation, whether it's tracheostomy care without ventilation, right? Similar to ICU, you wouldn't have support workers in ICU for ventilation and tracheostomy. So why would anyone in their right mind do that in the community? It would be like flying the airplane with the cabin crew instead of the pilot. Think about that, right? So I also encourage you to reach out, to us here at intensivecareathome.com, as quickly as possible. If you are in a situation where you need help, not only for MND, but also, cerebral palsy, spinal muscular atrophy, spinal injuries, we're here to help you in similar situation, including helping you with the advocacy, right? We also have a very good and big network of equipment suppliers, when it comes to ventilation setups at home, what ventilators to use, what suction machines to use, what nebulizers to use, what humidifiers to use, even setting up the hospital bed hoists, whether it's a ceiling hoist or a portable hoist. We have a good network of OTs, physios, or speech therapists. We also have a good network, not only our own NDI support coordinators, but also of other NDI support coordinators. We have a good network there. But even if you are watching this and you are an NDI support coordinator and you're thinking, oh, I didn't realize that MND patients can go home on BiPAP or CPAP. MND patients can have a tracheostomy and go home with ventilation and can go home with NDI funding. So this video is also for you. This video is also for you, for NDS support coordinators, right? So that's really good. So don't give up, don't despair. We can walk you through getting 24-hour nursing care at home step by step, but we can also do it for other conditions, of course. But this video is uniquely for MND because unfortunately there are many MND clients in the community that don't know what to do, that are at risk of dying, right? That are at risk of dying, and home mechanical ventilation is safe, a safe, effective clinical alternative to prolonged ICU care, and it must be delivered by 24/7 critical care nurses as per the mechanical home ventilation guidelines. The setup includes ventilation equipment, monitoring, suctioning, humidification, and cough assist, with ongoing clinical governance and medical oversight, which is essential, of all of which we can provide with experienced ICU nursing staff, but also with our own intensive care consultant, medical consultant. The model saves hospital beds, it saves lives, and it keeps families together. So our model works that we bring the ICU into the home with 24/7 CCRNs and ICU nurses, hospital-grade ventilators and monitoring, tracheostomy and BiPAP management, cough assist management, medication and PEG management, regular communication with treating physicians, also, catheter management if your loved one chooses to have an SPC or an IDC. It's really hospital level care, but in a home care environment, more humane, more private, more dignified, more respectful. So what are the clinical benefits? Once again, improved quality of life, reduced ICU-acquired infections, enhanced psychological well-being, family participation in care, proven cost effectiveness, of course, and evidence shows home care reduces hospital readmissions and extends survival, right? These benefits are supported by the home mechanical ventilation guidelines, which are evidence-based, and our success for over 13 years now, successful operations in Australia, right? So clearly this has been a success for such a long time now that we can only encourage you to reach out to us, and join the conversation by leaving your comments below, where you're joining from and what challenges you're facing with MND and ICU care. I respond to every comment myself, And once again, number one, we have a membership for families of critically ill patients in intensive care. If you go to intensivecarehotline.com and you click on the membership link, you can join there. And if you need help, I also do one-on-one consulting for families in intensive care, one-on-one consulting and advocacy. And then if you need intensive care at home, I encourage you to go to intensivecareathome.com and you reach out to us there on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. we have, we are employing hundreds of years of critical care nursing experience combined. You will be in very good hands. And we have clinical operations manager, we have state and nurse managers, we have clinical educators, we have, like I said, we are employing hundreds of years of critical care nursing experience combined. Also, we are the only service in Australia in 2025 that is actually accredited, third-party accredited for intensive care at home. No other service provider in Australia has achieved this high level of accreditation and has built the intellectual property for intensive care at home like we have. So, and to sum it up, today you learned about the truth about MND and ventilation options in ICU and at home, how BiPAP and tracheostomy ventilation can be managed safely at home, why 24/7 ICU nursing is absolutely essential for ventilated patients at home, and how to use the cough assist, how we use the cough assist to prevent infections and improve breathing. And I've given you some real case studies of MND patients living at home on either BiPAP or with the tracheostomy and ventilation. So if you need NDA support coordination, also reach out to us. We can help you with that as well. So I do want to wrap this up here. Thank you so much for watching. Thank you so much for watching. Like the video, subscribe to my YouTube channel for all updates, click the notification bell and share, most importantly, share this video with your friends and families. I will do another YouTube live next week around the same time with another topic. Thank you so much for watching. I will talk to you during the week. Keep an eye on my YouTube channel and on the website. Take care for now.